So my name is Natalia Curton. I'm a hematology consultant in Guys. I'm kind of specialized on MPN, and PV is one of my kind of favorite disease. So I'm just going to go through a few things. And obviously I'm quite happy to be stopped and we can have a chat later about cases or whatever is needed. So I'm just going to do an overview, obviously, of PEV and then talking about the main diagnosis, clinical characteristics, and management. And obviously talk about the different treatment options that we have, but also some of the new therapies that are coming up for PV. So that's just my disclosure. So obviously, as you know, MPNs are these kind of red blood conditions with an abnormal production of myeloid cells. In the case of PV, obviously, of course, with a high hemoglobin, platelets, and white blood cells can also be elevated. And they all doing because of this JAK2 mutation in the path of this JAK2 alteration of the pathway. And usually, we always been saying that the MPNs are more in patients over 60 to 70, but the reality is that we are seeing more and more young patients with these conditions. And actually, we in our clinic we have patients, a lot of patients over 40, and even we have some teenagers. I called a patient the other day that she's 16 years old now. And so obviously we probably will see a change on that, and I'll be interested to see what is the prevalence in your community as well. Obviously MPNs are different type of, but I'm going to focus on PV as I mentioned. And this is obviously, just as you well know, just to give you an overview of what is the pathophysiology in MPN patients. So you have your stem cells and then they start proliferating because of the alteration on the JAK2, which could be in different genes. And then they just carry on. This is clonal heterogeneity. And obviously they can become more aggressive and go into leukemia. In terms of the main driving mutation, as you know, there are the JAK2 B617F, but we also have MPL and CALR. And in particular in PV, obviously, we have the exon 12. And we still have a big proportion of patients, mainly in ET and MF, that they don't have any, there's a yellow one, mutations. There is a small proportion in PV that they have all the characteristics, but we don't catch up JAK2. And it sometimes could be quite challenging, to be honest, to diagnose those patients, but we do see those. And I think maybe we're just catching that quite early. The JAK2, we can't detect it because of technology. The spot would be much better. And then the other thing I just want to add in here, which I will also show later, is obviously some of these other mutations that we can find in our patients. This is more specific for myelofibrosis patients, but in some quite aggressive PV patients, you can also have maybe a type 2 mutation or other mutations. And as I mentioned before, basically this is what will happen. So you have your EPO receptor with the JAK2, it's an alteration there, and then just go on, increase the proliferation, cell activation, apoptotic, and differentiation. So all of those pathways will be affected, and then we'll see the proliferation in peripheral blood and in the bone marrow. As I mentioned before, this is a nice summary of the different mutations that we can have in MPN patients, more common in MF, but it could be also in the other disease. And this is just to show you the importance of these genes. So obviously, with all of this in mind, I always like to put like a clinical case, which I think reflect what we all see in our clinical practice. So this is a typical patient with 65 that present with headaches and fatigue. He has a recent infection, so GP was like, okay, fine. Has a medical history of hypertension, but nothing else, and maybe was a potential TA years ago. So the GP does the bloods, and as you can see, he's anemic, his platelets are high, the white blood cell is high, that could be because of the infection, and his iron deficiency. So obviously, we investigate for the iron deficiency. Here we organize like a fit test. The GP starting with iron, and then when they repeat the bloods a few weeks later, because he was continue with the fatigue with not clearly improved, the hemoglobin has significantly high. So obviously, and the PCB as well. So clearly he was like, well, that's not normal. So went to the heme team. And then we did all the investigation and we found the JAK2 positive. So at this point, there's always a discussion: do we need to do a bone marrow and abdominal ultrasound? Which I would probably say yes to have a confirmed diagnosis. But obviously, because of the hematocrit, we start with venesection and aspirin, and then we'll discuss if this patient needs cytoreductive therapy. So obviously, this is one I go more deep on what is PV. So as you know, is the most common is the most common MPN. So I mentioned age presentation about 60, but we can see more in young patients as well. It can come with not only erythrocytosis, also thrombocytosis and leukocytosis, and in some patients even like a larger spleen. And obviously, as you know, the most common mutation is the JAK2V617F, and this is a typical bone marrow in a PV patient. One of the important things with PV patients when they come to the clinic and you just start, asking questions about how they feel, you can have patients that have obviously no symptoms, but it's true that most of the patients have a significant fatigue. And this has been so in this study from a few years ago now, because it's going to be 10 years next year, with Prof. Harrison leads on that. And we saw that about 45% of the patients with PV have fatigue. They also have pruritus, as we know. Aquagenic pruritus is one of the most common ones, or the most characteristics. They can also have dizziness, loss of concentration. Some of the patients mention as a brain fog sensation, etc. But what I think is really important is notice that majority of the patients, about 72%, describe a significant impact of the MPN symptoms in their quality of life. And that will reflect obviously in work productivity, career progression, and even some job opportunities. So it's really important to think about this when we confront patients and not thinking, well, PV is just red cells, high, go to your venesections, and that's it. And the other important thing that I always try to make everyone aware is the way that patients with PV can present is with a thrombotic event, and this can be up to 40% in as a first presentation. And this can even occur 2 years before you do the diagnosis. So if you see a patient with an uncommon location, a hepatitis portal vein, CVAs, or a heart event in a patient that's young and otherwise well, you always have to keep in mind this condition. And curiously, for instance, in patients that have splenic vein thrombosis or portal vein thrombosis with Chiari syndrome, the bloods can be even on the normal range. So I have a few patients that the bloods are totally normal. So you will not, pick a diagnosis unless you actually kind of looking for that, digging on that. And I think this is really important. As I mentioned, you can see here that most of the patients with a thrombotic event will lead most of the patients with PV can present with a thrombotic event, and it's either arterial or venous thrombosis, but it's quite a significant ratio. And this also can happen a few months after the diagnosis. So that is the critical moment, if you allow me to say, for manage this patient. And we have to be quite aggressive to control the counts. And this is also basically, so it's pretty much the same, right? So how we detected the prevalence of these events, these thrombotic events in our patients, and how they can also contribute to mortality, and compare it with normal or control cases. In the recent years, we have tried to obviously making better scoring systems, and one of them is looking as well on the arterial and venous thrombotic events. So this is two proposals, thrombosis scoring systems, which it will potentially help in the future to decide what's the treatment options in view of the classification. I will present later the standard classification that we use at the moment, but this new thrombotic score system will potentially have an impact later on. They're not full validated yet. But as you can see here, they, apart from obviously the personal thrombotic event, they're also looking on, do you have any cardiovascular risk factors? What is the age of the patient? And also what's the mutations? And for the arterial ones, they take the TEC2 and the NMT3A. And in the case of the venous, they talk about the JAK2 BAF more than 50%. And there's actually a few studies from the Italian group saying, if your BAF is that high, we should consider treatment, even if you don't feel of the criteria like age or presence of a venous thrombotic event, because they found this link between a high JAK mutation with a thrombotic event in the future. And so obviously, just continue with our case with Mr. Smith. The decision was obviously to start cytoreductive therapy, and we did complete the bone marrow, which confirmed the diagnosis, and he also has a large spleen. So the reason I bring this stratification I mentioned before is, apologies, some of the emails are coming in, is to show you what's the current stratification that we have for PV patients. So it's well known the high risk, so age 65 or 60, depending on the country, we go for the 65, and presence of a previous thrombotic event associated to the PV. So then in those cases, you have to be more aggressive. So venesection, antiplatelets, anticoagulation, obviously if you have a previous thrombotic event, and cytoreductive therapy. And then the low risk is any other patient that fill these criteria. However, and this is a really nice update from the BSH guidelines, with Professor Mary Francis and others been reviewing this, and they say, well, hold on a second, if you have a low risk, but you have cardiovascular risk factors, high white blood cells, extreme thrombocytosis, so platelets over 1,500, or a hematocrit that we can manage with just venesection, you need to start on treatment. And then this is important to discuss with the patients, right? I guess, obviously, if you also bring in like quality of life and symptomatology, I think it's important to, think about that and have the conversation with your patient. And this actually brings, sorry for the slide should be before, but there's some limitations with the risk scoring systems that we have, and obviously some of those looking on the cardiovascular risk factor and the presence of high risk mutations. If we're looking on that, patients will reclassify. So we probably, as I mentioned, we may need to bring more other factors to the standard risk factors that we have for the stratification of our patients with PV. And I think it's important, right? Because things are moving, and obviously I'm talking from our perspective in the UK, but I think we are seeing more and more young patients with cardiovascular risk factors like hypertension, diabetic. And so I think that's potentially will have an impact going later on in life in PV and increase the risk of a thrombotic event. So that's what probably is important to think about it. And that brings to these slides, right? So on the REVEL study, which was a really large study, we saw that there was majority of the patients with PV, like 77%, have more than one cardiovascular risk factor. So, I think it's important that we start keeping this in mind and thinking, actually, we need to action not only on the cardiovascular, or push for the cardiovascular risk factors to be controlled, but also thinking about the impact in the PV patients. And you can see, apologies, it says in Spanish because I did talk in Spanish. It has a negative impact in the survival of the patients when you have more than one cardiovascular risk factor. I mean, the lines are really nice here. So I think this kind of, we should keep this in mind, as I say, if we manage your PV patients. And this is us linking with I mentioned before. So we know now that the presence of the JAK2 mutation has an impact on thrombosis. And if this BAF is over 50%, that is more significant, even on the low risk patients. So obviously on the high risk, you can see it's beautiful survival curve here, but that's also reflect on the low risk patients. And this is just more data from the REVEL study. So you can see that they're not only looking on the cardiovascular risk factors, as I mentioned before, they're also thinking about what is the impact of high white blood cells, which I think is really important, right? Because obviously I've been working on MPN for the last 10 years plus now. And I can see a little change in the way that we manage mainly PV. So before we were super focused on the hematocrit levels. Now we are kind of open our mind and say, well, wait a minute. What about cardiovascular risk factors? What about high white blood cells? What about high platelets? So, we are looking at PV more as a big picture, not only just the red cells. So I think it's important. And these studies just reflect that that actually, the white blood cells can have an impact on our patients. And why I'm saying all of these? Well, if you look on the life expectancy of PV patients, when we have a high risk patients, they can have 40% estimated mortality at 4 years. So actually, it's important to think about what is going to be the future of my patients. And I know the low risk don't have that significant one compared with the high risk, but it's still there. And this bring to as well this lovely slides that Prof. Harrison passed to me a few months ago. And you can see that the annual rate of thrombosis in PV patients compared with the general population, based on this study in 22, is still quite significant, even on the low risk patients. So it makes you thinking, are my PV patients with low risk really not on any risk? Well, looking on this, probably the answer is no, because you still have a high level of incident of thrombotic event when you compare with the general population without the risk factors or with risk factors. So I think that's also another important element to keep in mind. So if I just move quickly to talking about the classic therapies, which I know most of you obviously are really familiar with hydroxycarbamide. It's been on the market for 40 years plus. It's a well-known medication, gold standard in managed patients with PV and other MPNs, and it has a really good control on hematocrit and reduced thrombotic event. Obviously, it has side effects. There is this risk of leukemia transformation that was described in articles back on the 80s when they compare with things like bisulfan or phosphate irradiated, which is quite leukemic medications. And it has significant side effects, which I go through with my patients. So apart from gastrointestinal symptoms, as many other medications, the most, or for me, the most important ones that we need to try to prevent is the skin cancers, which is something that has been clearly described. And skin ulcers and mouth ulcers are also really significant in these patients. And most of the times that leads to change the therapy and thinking of alternative. I have further questions for you. It's nice to see what's the rates of skin cancer in your country, because in the UK is quite significant, and obviously when we add in these medications, it goes higher and higher. And that's, I think, brings to these slides where we'll need to look on what's the resistance intolerance for hydroxycarbamide, because that's important to think about second therapies. I have to put my hands up. We're not that good sometimes in our clinic, but I teach my registrar to look in on this. But obviously, any patient that is been with a high dose of medication and develop, continue with phlebotomies, or the bloods are uncontrolled, you haven't touched the spleen, and the symptoms are significant, that patient is probably not going to respond. And obviously, the other way, when they have significant neutropenia, or when they have thrombocytopenia, and even if they're on a low dose of treatment. And as I mentioned, the presence of mouth ulcers, leg ulcers, or any other toxicity that you think the patient is not going to manage. So this is something I will try to look in the clinic, as I say, but as everyone, we have busy days, so sometimes you miss this. And apologies. And why it's important to look at? Well, we know patients, if they have resistant intolerance to hydroxycarbamide, there's an impact on the survival. And this has shown by a few colleagues from the Spanish group, when they see there is one increased transformation in leukemia or myelofibrosis, but also more risk of mortality at the end of the day. So it's quite good to see, and obviously it's important we identify these patients as soon as possible. So in the UK, we are able to treat patients as first line with either hydroxy or PEG interferon. And obviously, if you start with hydroxy, then you can pass to PEG interferon as a second line, and the other way around. So PEG interferon, there's different modalities at the moment, but the one we use in the UK is the alpha 2A, and we also have PEG interferon, which is alpha 2B. There are injection therapies. They can be taken, in the case of PEG interferon, every week, or you can expand that frequency. And the rock peg interferon, the doses are every 2 weeks. So you can do 2 weeks, 4 weeks, 6 weeks, etc. We try to use more in young patients, basically because it's the one that is safety and approved for pregnancy. So it doesn't have any affecting the fertility or the baby. So that's our first option. And it has demonstrated really good response in terms of hematological and molecular responses. And this was really, I guess, changed the way that we think about the relevance of the JAK2 pattern, because we start then after this study with the prod PV and continuing PV studies start talking about molecular response in PV. But basically, we saw there was a reduction on the JAK2 burden in patients that were on interferon compared with hydroxychloroquine. And in some of the cases, these were maintaining for 5 years. So some of the patients were, like they call, on a holiday, so they stop the treatment and they keep it on that response, which is really good. Unfortunately, have also side effects. And one of the most common one is flu-like symptoms after the injection, usually 24 hours, 48 hours after the injection. It can increase the risk of depression and anxiety, can affect the thyroid, general myalgias, and it can exacerbate some autoimmune disease. So I think that's, for me, the most important one. Obviously, depression and anxiety is tricky to manage because sometimes, there's other factors that can contribute to that, including the fact that they have, a cancer diagnosis, etc. But it's something really important to evaluate in a patients. And I have recently one patient that she just couldn't tolerate it anymore, because since she started, she noticed, she was really like rude, anxiety, stress, anything causing her like crying. So it was really, really, really difficult for her to be able to manage. And we stopped, and literally in like 2 weeks, she was back to herself and absolutely fine. So it can impact a lot in our patients. So it's important to be aware of. So this is just to show you a few obviously good response when we compare hydroxy, interferon, and all the therapies, and you can see how the response was maintained, the survival and the overall survival on the patient. So interferon has a really, really good outcome on this aspect. And this is coming from some of the studies with drop-back interferon that shows the nice response in terms of the hematological response. So drop-back interferon is kind of orange-red color. And this is, the graphic just speaks by itself how the JAK2 mutation drop really nicely. And this is month 60, so continues, maintain the response, which is really good. And then we obviously have other therapies that we can use in PV, like anagrelide and the busulfan, which, to be honest, I only use in really elderly patients as a last resource. Anagrelide in PV is a little more complicated because you don't have that much red cells. If you respond, it's good in patients with thrombocytosis, and in some cases we combine them, but obviously it has side effects. And obviously, as I mentioned before, antiplatelets is like mandatory for any patient on PV unless there is any major contraindications. And this is just come from this longest study, the ECLAP studies back, we're going to sound really old here, but 20 years ago, and probably some of you will be in medical school or even in high school. But it's a really, really nice study that showed that just giving aspirin and keep the hematocrit below 45 improve the outcome or prevention MIs, cardiovascular, CVAs, and P. So it's quite good study. And I always refer, and I probably will continue referring for the rest because it's really important. And obviously, in terms of anticoagulation, it's not limited data, have to be mainly with the DOACs, but both of them have been used, so both warfarin and direct oral anticoagulations. And then we normally go to an individual cases to decide if we want them with antiplatelets. I always discuss with my thrombosis colleagues, let's give them a call and say, look, what do you think? Because, if the patient is well managed, they may just continue with just the anticoagulation and you don't need the antiplatelets. In patients that have cardiac events, I will always check with the cardiology team, but I will probably in those cases maintain, because the antiplatelets is more from the cardiology perspective, or so it kind of, you have to go to an individual assessment. And obviously the venous sections, as you know, again, another really nice study, hematocrit below 45, that is the gold standard for these patients. Even there is now some studies that suggest you should be going lower than 45 in some cases, like patients with high risk of thrombotic events. But again, that goes on an individual basis. And this is obviously just to doing a quick summary of what is the response criteria for patients with PV on treatment. And you can see here, obviously, complete remission, partial remission, and obviously no response if there is not any of these, and progression disease when you found myelofibrosis or AML. And really briefly, bear with me one second. Talking about, because we still have time, yes. New therapy targeting PV. So I'm going to talk about ruxolitinib, which is probably the number one, second line. Hopefully we'll come to first line for PV. But there's other therapies going on, like the LSD1 inhibitors, hepcidin mimic therapies are on the clinical trial, and hopefully in the next weeks we'll have some results from the studies in the European meeting. But ruxolitinib is, as you know, a JAK inhibitor. It's been approved for patients with resistant intolerance to hydroxy, so as a second line. And we have now approved in the UK for that. This comes from the RESPOND trials. And I will talk a little bit about the MAGIC trial, because we run that in a hospital. We were one of the main hospitals leading that, and I have the pleasure to working on that study as well. What we saw as well with ruxolitinib, a really good response, which I'll show you in a minute, is also a reduction on the JAK2 mutation as PEG. So that's why in some of the cases, some patients now are starting to be like, oh, can I just have the ones that reduce the JAK2 mutation? And I think we still have to collect more information for Rux, but it looks really, really promising on that. As you can see in summary on these two studies. Side effects, as well as other medication, GI toxicity. Rux can cause anemia and thrombocytopenia at the beginning of the treatment, which obviously most of our patients with PV is fine, but we have to be really careful because you don't want the patients to crash the counts. It can increase the risk of infection, and another one that can increase the risk of cancers, skin cancer. So it's really, really important to, monitor that and ask the patients to, if they notice any skin lesion, to highlight that immediately. And the other big problem for ruxolitinib is increase on the cholesterol levels, which obviously I've been talking about cardiovascular risk factors, so it's really important to monitor that and treat as needed. And the other important thing to keep in mind is we should not stop suddenly ruxolitinib, because it can release all of these cytokines and have like a withdrawal syndrome, which could be really significant. Now, as I said, I will talk a little bit about MAGIC study. So MAGIC was a phase 2 study randomized between like 1-to-1, and we randomized between the base available therapy and ruxolitinib, and they were in high-risk patients that have intolerant resistance to hydroxycarbamide. Obviously, the base available therapy could be continued with hydroxy and PEG interferon, or in some cases busulfan or other therapies. And then we continue this study for 5 years. I will tell you the number one patient, which was from us, is still on the treatment for however long is now, and he's absolutely fine. And I'm allowed to use him as example because he has advocated for ruxolitinib to be approved in mice. So this is the response that we have with ruxolitinib versus base available therapies. In this case, it's in red. So you can see the duration of the complete response was really good. The time to discontinuation was lower in ruxolitinib, so more patients would discontinue the therapies in the base available therapy. And the event-free survival was also good, and the same was maintained when you can keep response. So overall, it was superior on ruxolitinib, and similar to the previous studies that we saw with response and even on the comfort studies for myelofibrosis. This is the symptoms response. So again, you can see the improvement on the symptoms in red for ruxolitinib versus the base available therapy over time. So this is 6 months. And this is the molecular response. So what we demonstrate is patients achieve molecular response after 1 year, were corresponding to superior event-free survival. And those that we have a durable molecular response will have better event-free survival, progression-free survival, and overall survival. And this was just over the first year of therapy, which it was really good. And that was maintaining more or achieving better by the patients with ruxolitinib than base available therapy. So you can see here as well that depend on the drivers. If the patients have only one mutation, the event-free survival was better. If they have more than one mutation, obviously the event-free survival was worse. And specifically with AXL1, you can see the massive drop when the patients have this mutation in terms of the event-free survival. So that was something important that we did on this study. It's not only looking, as mentioned before, in the JAK2, we're also looking for other other mutations. And we found some of our PV patients, high risk, they have other mutations, but they have not had myelofibrosis. Okay, so that was really important to demonstrate that. And this is a project that part of the MAGIC study one of my colleagues did, Dr. O'Sullivan, when she took single cell investigation and looking if the mutation was also reduced on that. And in patients with ruxolitinib, we also noticed that JAK2 was reduced down on the stem cells. So deeply down on the actual, problem, if we want to, ruxolitinib has an effect. Obviously, as you know, these studies, it was 3 cases we put here. There was more, obviously, we're looking in all of the stem cells for the patients that we were able to access. But, it's quite nice to see that actually ruxolitinib can reduce that mutation in the stem cells, which has, you go to the bottom line of the problem. And why I'm talking about this is because we have a study in phase, early phase for these patients in frontline. So similar picture of PV patients with high white blood cells, and we put them in ruxolitinib as a first line or base available therapy. And this study is ongoing, and hopefully we'll have some results coming up soon. It's quite nice and promising. And then just talking about all the therapies that are coming, because again, as I said, I've been working a long time at PV, and finally we're moving beyond the classical therapies with hydroxy and PEG. So we have RUX, but we also have these new therapies, which are the hepcidin mimic, which they target the iron metabolisms. And the main idea is to regulate the iron, and mainly in PV patients will be to reduce the needs of venesections. So this is the drug rusferetate, which has been now approved in America. And the idea is basically to reduce the need of venesections. There is a question if they add in or not cytoreductive, so combined therapies, because it looks like the drug works mainly on the red cells and venesection, not as much on the symptoms and the white blood cells, etc. So I hope there will be more results on this. I know the studies are coming, and they're planning to do more studies to look on the long term. But it looks really good, obviously, if you think young patients, venesection needs, it may have a really important impact on the quality of life of this patient. So the studies, as I said, are ongoing, and I hope. I don't have access at the moment to this drug, but we'll hope we'll have that coming up to the UK. And all the studies that are unfortunately being on pause and tried, but not showing that nice results are the HDAC inhibitors, so barinostat, gibinostat, but I just mentioned here, but I'm not going to go in detail. And similar to the osimertinib and the inhibitors. So a lot of things going on, but unfortunately, some of these studies or either still going or we don't have many results yet. And the other one that I hope will have another update coming up in the European meeting in a couple of weeks is bombenostat. So this is more an LSD1 inhibitor. We did have a patient. We managed to put a patient on a clinical trial here, which he responded really nicely, stopped venesections, improved on the symptoms. So it was really good. So I hope we'll have more results coming up. But obviously, I can't say anything because confidentiality business. But I'm looking forward to this one because actually it looks a good drug. It's also in use in ET patients and MF patients in combination or alone, so it's quite good and promising. So obviously there's all the therapies on the pilot and hopefully will come to us, but we'll see. So I think with that I will conclude now. We probably have some time for questions and talks, and I can see all your faces. But just to say, obviously, I think it's important to think on PB, not only on the red cells, a little bit beyond that. As you see, the white blood cells the level of white blood cells is important. The JAK2 buff is having a more relevant in the management of these patients, but also looking on your patients and the symptoms and how is that affecting the quality of life. Okay. Obviously, the therapies that we have available is still really good in control the disease and the symptoms of the patient. But again, it's important to ensure that your patient is responding. And if you're thinking it's not, then have a second look because there is possible options, and I hope you have more options than just hydroxycarbamide in your country to think about change therapies. PEG interferon ruxolitinib are good in terms of molecular and prevent disease progression. There is new therapies, which is always a positive thing. And obviously, we talk about the molecular response. I think this will come and change the way that we manage this condition. And the other thing I would like to add on here that I didn't add, but I mentioned several times, is obviously the presence of cardiovascular risk factors. Try to prevent that because that has a significant impact in the general health of our patients. But obviously, if that patient ended up having a thrombotic event, that could be significant in terms of comorbidity or even mortality for the patient. And I think with that, I will conclude and say thank you all and open to questions. I'm going to start sharing so I can see not only just me talking. Thank
you
you.
very much, Natalia. That was really great. Do you guys have questions for Natalia while you were here? Please. Everyone's very quiet.
No, I have few questions.
Wonderful. Please go ahead, Sahar.
So first of all, what is the role of evaluating the erythropoietin level? How important it is in cases if we are suspecting polycythemia vera? This is the first question. Second, how important is bone marrow aspirate and bone marrow biopsy? Because in most of our cases, we don't do bone marrow. We depend on sending the patient for the JAK2 mutation molecular. Third point, if we test the JAK2 mutation, is it preferable to be done from the bone marrow or peripheral blood is enough?
That is actually, sorry, go ahead.
I think let's answer these three questions.
Yeah. They're really valuable questions. So I will start for the last one. The JAK2 you can do on peripheral blood. That is, if you have a good molecular service, that should be plenty enough. And actually, most of the time, we do on peripheral blood to start with. To answer my question, answer your question. The question I will answer next is the EPO. 100% yes, super value. It's really helpful. Mainly, I will do in all the patients I'm thinking they have a high hemoglobin. So my patient come with a high hemoglobin walking in the clinic, they are going to have full blood count, renal, liver, EPO, iron, and a JAK2. That is my base things. The reason I'm saying that is because if you have, and I know the bone marrow, I know the guidelines say we need to do a bone marrow, but if I have a, I don't know, 85 or 90 years old patient that really I'm going to do a bone marrow if I have a good JAK2 EPO and a hemoglobin of 170, PCV 0.6, really I need to do a bone marrow? Probably not. I know what I need to, it's quite clear, the management. So it is a bit debate about the bone marrow, and that's what I left out for the last question. Yes, we should do, and it's part of the criteria for who and for BSH, but I guess you will go to individual cases, right? If you have a really good lab that gives you the JAK2 on peripheral blood, a low EPO, because EPO is really important actually. And in the guidelines from BSH, it's really nice to see like, okay, EPO is part of the investigation, because if you have a JAK2 negative, exon 12 negative, your EPO is high, then you need to do other investigations to understand why it's that. So it's key on the research for investigate your erythrocytosis patient. The bone marrow, I'll be honest, we don't do in all of the patients. So I will go to an individual cases. I will also add, I will do a scan to check for the spleen as well. And also help you to see if there is any renal problem, which it could be. We have a few patients with renal carcinomas and a PV at the same time. So it can be quite, both of them contributing. So excellent question. Don't know if there's any other ones. So the chat.
I can ask some more if no one has.
Go ahead.
Okay. So, like many of our cases, because we are limited resources, so we always depend on testing the JAK2 mutation. Sometimes even exon 12 is not available, or the patient can't afford to do everything. So in cases that we have oxygen saturation normal, ABO normal, even JAK2 mutation is negative, we do still treat the patient as polycythemia, and sometimes they don't have splenomegaly as well. So how do you look at these aspects, or is that okay, or anything we can do more to conclude the diagnosis that they are really polycythemia vera?
Yeah, so obviously if you cannot do the exon 12, I think on those cases I will try to do a bone marrow, just to confirm, that you're talking about truly a truly PV patient and it's not a secondary erythrocytosis or idiopathic. But it is difficult. Yeah, I think on those cases, if you can't access to the exon 12, I would probably go for a bone marrow.
Yeah, thank you.
That's all right. That's good. And am I allowed to ask a question just out of curiosity? In terms of treatment, you have access to hydroxy and interferon, or is
No, it's only available as a hydroxycarbamide. There are few patients that they came JAK2 mutation positive, and they were capable to access the monoclonal therapy.
okay?
The rituximab, yeah.
So,
yeah. So these are, but mainly we depend on the hydroxycarbamide and the aspirin for treatment with the venesection.
Yeah. Okay. Thank you.
For cases that has normal platelet count, is it also advisable that all the time we keep the patient on aspirin?
Yeah.
Okay.
I will only stop aspirin if the platelets drop to below 50 risk of bleeding, or if there is some cases we stop when they are really high, so 1,500, because it can increase as well the risk of bleeding. something I have learned from experience, but yeah, otherwise I will always give the aspirin unless obviously it's contraindications, or you can use clopidogrel.
Okay, thank you so much. Thank you.
So much.
Sorry for keeping our cameras off just for the network connection. We have like weak signals, so sorry to keep the cameras off.
That's all right. I have internet problems before, so I was really worried that we couldn't do the talk at all. So the whole trust dropped their Wi-Fi. So it's not, it can happen anywhere on the world.
Thank you.
Good. Yvonne, you're mute.
Thank you. I was going to say, if there are no other questions, then we'll let everyone go. Oh, yes, that's a note. I've just sent the link. There is a link there for the previous recordings, and once this one has been edited, it will also be available. Oh, someone's put their hand up. Yes, please go ahead.
Hi, good afternoon. My apologies, I missed the part on treatment. I'd like to know, apart from venesection, what treatment modalities that you're using. I know we use a lot of hydroxyurea as first line, and a few of our patients have used JAK2 inhibitors. Of course, they haven't given that extra like better outcomes than hydroxyurea alone. So I'd like to know what treatment modalities.
Yeah. So obviously, at the moment in the UK, first options are either hydroxy or pegylated interferon as the two main options we have. And then as a second line, we have ruxolitinib. I mean, the three of them are good. There is no studies that compare the three of them except the one that we're running at the moment. I guess obviously hydroxy is the standard goal, as I mentioned, so good response on everything. PEG interferon, a part of good response on the hematocrit and the blood's hematological responses, also has a good impact on the molecular, so the JAK2 BAF reduction, reduction of the spleen, and reduce the risk of disease progression to myelofibrosis. So you have seen some reduction on that as well. I mentioned about the side effects. So it's an injection. Obviously, you have to keep it also in the fridge, which sometimes could be a problem, I imagine. And the dose is weekly. They can have flu-like symptoms. They can have anxiety, depression, thyroid toxicity. So there's all the side effects of that medication. It's really good for young patients because it's the only one allowed in pregnancy. So it's safety for that, which is really, really handy for some of our patients. And then in terms of the ruxolitinib, you did briefly mention that you have not seen that good response in your patients. And overall, it's always really good response in terms of the symptoms and complete hematological response, and also reduce on the JAK2. What I would probably say, really talking a little bit for experience, don't have any data collection, but symptoms-wise, most of the patient improve more quick than you will see a response on the blood. So it usually take, I will say, probably 2 to 3 months to achieve a response. And curiously, sometimes in PV patients with high platelets, it can take a little longer. You have to be patient with ruxolitinib, I guess. And obviously, if they come from being resistant to hydroxycarbamide, sometimes we overlap them a little bit. So, I can do a whole talk about Rux as well on PV patients. But it's overall a really good drug, and I'm quite curious that you can access that one. It's more expensive than PEG interferon. So it's good though. but because it shows really good response in general in patients. But yeah, do they have like private access, I guess, for the ruxolitinib? Do you?
Private, yes, they have to get it themselves.
Yeah. Have like self-financial. God, it's expensive.
Yeah.
Yeah.
What I meant was it hasn't shown a better outcome than those on hydroxyurea. So patients stabilize, yes, but
Yeah.
we haven't seen the superiority.
Yeah, no, I mean, I agree that I think one of the studies we are running at the moment is as a first line and will be compare hydroxy, well, it's base available therapies, but there's a big group of patients with hydroxy and ruxolitinib as the other arm. So it would be really nice to see, as a baseline with no any other therapies before, what's the response. But it's curious though that sorry, Yvonne, we probably can't carry on talk. Sorry, I'm so curious about lots of things. But do you have a more young population though?
I'm not sure, but by young, most of our patients are 50 plus.
Okay.
So
Well, that's
70s, yeah.
That's young patient.
Yeah,
Yeah.
we have a few in our 50s. And I think, Dr. Saha, we have some even in our 30s, eh?
Yeah. Okay.
With PV, yeah. JAK2 positive.
No,
Yeah.
we have young patients. They even come early 20s
Yeah.
with polycythemia. Yes, even one of them, they came after developing thrombosis and was not in a good condition.
Yeah, I'm curious because I wonder if it's also, I mean, obviously depends. This is like everything, right? One patient responds perfectly well to a treatment and another doesn't. You can give him like 5 therapies and it's not responding to anything. But it would be nice to see what is, any other factors that can affect those patients if they're really resistant or really active disease, because that's, I agree with you. Sometimes in patients that are really proliferative disease, it can, the response may not be as good. And don't get me wrong, hydroxy, the fact that it's a drug has been for more than 40 years, so clearly it's a good drug. The difference now is we have more targeting therapies, but I mean, we still use hydroxycarbamide for so many disease. So, it's not a bad drug. It's just we probably have other that are better, but it would be nice to actually. I just can I sorry. I'm wondering if we can have a conversation about these cases, because I wonder if we can look at that together, because I'm just so curious that some of your patients has not responded well. I don't know if I'm allowed to do that. If I'm sorry, I'm just creating, collaborations. But I'm quite happy to work on an email and just have maybe looking on cases together. It would be really nice. This is a learning for me as well.
Yeah, I mean, it certainly would. Yeah, I mean, sometimes we get stuck, and we also need to consult. There's some of these drugs we don't have much experience with, like JAK2 inhibitors. It's a new experience for most of us.
If the team allows me to write my email, I can write my email in the chat, and I'm really open. Is that okay, Yvonne? Is that thumbs up? I'm quite happy because it's quite as you said, we all learning for experience, right? For me, been working on this for more than 10 years, and you have experience, but also, right, there you go. Anyone can contact with me. Oh, yeah. Good.
Okay, great. Thank you.
Thank you. I can always come to Zambia. Oh, man.
Oh, that would be awesome.
Yvonne, you're on mute. But yeah.
Again, I'm trying. So we're waiting and hoping for an HVO agreement with the BSH to be signed with Zambia, and we're wanting to promote this work. So Josh Wright is the main lead. I'll let him know that you've put your email and we'll be collaborating, and we can include you in some of the things that we're doing. So there should be opportunities to go out. Yeah. So there was a question in the chat. Drug of choice for an anticoagulant in PV.
So that's depend on your access. I think for us we use any warfarin, apixaban, rivaroxaban. So there is not any major preference. I will be guided off the access that you have. Obviously, now that with the DOACs, they've trend more to use apixaban or rivaroxaban. But if you have access to warfarin, that's absolutely fine. So there's no many data on DOACs either on MPN in general. So
I don't know, do you get DOACs there, guys, in Zambia?
Yes, we have.
Yeah.
Yeah.
Lovely.
Fantastic.
If there's no more questions, thank you very much, everyone, for attending. Thank you, Natalia, again for speaking.
Yes.
Please put your feedback in, and yeah, reach out, and we'll see you next month.
Thank you so much. Have a lovely day, everyone.
Thank you. Bye.
Thank you.